Jupiter plans here. A pogo.
Hello, everyone. Good morning. Can you hear me?
Yes.
Okay. I'm Dr. Dattoli, and welcome to the cafe. I'm here to answer any and all prostate questions that you may have. If you don't have any questions, I'll just talk. I'm pretty good at doing that. So anyhow, I do want to thank Jeff who sponsored the breakfast of Johnson & Johnson, also known as Janssen, and they provide some very interesting new drugs, which we didn't have not that long ago. Historically, cancers have been treated with chemotherapy, as you all know. The problem with chemotherapy is it attacks the entire body, every cell of the body. It's basically a type of poison that happens to kill cancer cells better. And in many cancers, it's what's necessary. It's all we got. But in prostate cancer, we got a lot more. So we don't commonly use, at least here, we don't commonly use chemotherapy. Although there are some patients who do need that, but we try other things first. And those other things typically work pretty well. Hormonal therapy is the common agent that is used for prostate cancer, since it's primarily fed by the hormone testosterone. But there are other elements that feed it as well. But the classic traditional hormones, they block the production of a hormone coming out of the brain. The hypothalamic pituitary axis of the brain secretes a hormone, which then goes to your testicles and typically makes testosterone. Well, that hormone is shut down. And so it shuts down the production of testosterone from the testicles. Based on that, you get an immediate drop of testosterone, and the food chain for the cancer goes away and the cancer starves. But even the hormones have side effects, not nearly to the level of chemotherapy, but these new drugs that I refer to, what they basically do is they don't drop the primary hormonal axis testosterone production. Instead, they block the testosterone from touching the cancer receptor. So they're called androgen receptor inhibitors. So they're kind of a new wave of treatment. Now, all of the data with hormonal therapy, however, does still use primary hormonal therapy. So what we commonly do is do both. We tag the secondary line agent, androgen receptor inhibitors, along with the primary agents. And in many patients, we then come off the primary agents and just use the second line agents so that the testosterone can actually recover, because it's not blocking the testosterone from its primary origin. Anyhow, does anyone have any burning questions at this point regarding anything? Yes.
Biopsies. Get a biopsy, don't get a biopsy. You think you have advanced prostate cancer. Do you need to get a biopsy? Because it seems like all the urologists require it.
Okay.
And I'm not really
sure. So the question is, when to do a biopsy? What is it? Why do you need a biopsy in the first place? So prostate cancer is common. And fortunately, unlike other cancers, it makes a specific molecule that we call PSA. It's specific to the prostate, and PSA stands for prostate-specific antigen. That's unique. It's been around for a long time, but let me tell you, other cancers would like to have that around, something like a pancreatic cancer, GI malignancies in general, and lung cancers. They don't have it. With prostate cancer, we do. And for that reason, men of age, and I typically think probably age 45 and greater, should be getting their PSAs checked. And depending on your family history, you may start at even a younger age, 35 to 40. But it's a test that will pick up prostate cancer earlier than other ways of looking for prostate, because prostate cancer, when the PSA is rising, you may have no symptoms at all. It's just that PSA elevation that's getting your attention or getting your doctor's attention. Now, the total PSA, however, is not the end all. So, for example, someone may have an elevated PSA, and it doesn't mean there's cancer, because after all, every prostate cell makes PSA. And so, that being the case, for example, a big prostate gland has many more cells, and it'll make many more PSA molecules, okay? On the other hand, cancers, by virtue of being cancers, are growing faster. So they're actually growing faster and making more of that PSA. However, as cancers mutate and they become more aggressive, they actually make less PSA. So you kind of have to figure it all out. But a general rule of thumb is it's not as important with the total PSA. What's important is the rate of the rise, the changes associated with the PSA. So, for example, if a person has a PSA of 5 or 6, doesn't get my attention that much, but if I knew that 3 years ago it was a 1, and 2 years ago it was a 2.5 or 3, if it's going up like that, well, something's making that happen. But there are cases also where you can have a very high PSA, and it's not because of even prostate growth, it's because of prostate inflammation, something we call prostatitis. So prostatitis in and of itself produces a lot of PSA, because it inflames the heck out of all those prostate cells, and they just shed their PSA, which is a molecule they're all making. So PSA is important. However, the rate of the rise and some other aspects along with it. But if a PSA is elevated, then typically your doctor will do what's called the DRE, digital rectal examination. Although I'm noticing a lot of doctors not doing that anymore. I don't know why, but I do it on every patient when they first come in for an evaluation to figure out what's going on. Because if, again, your PSA is elevating and you're identified on a DRE to have a hard spot or a lump in the prostate, well, that's important too. But anyhow, many of you will not get a DRE, okay, and that's interesting. But because of the PSA rise, we then look at other factors. Do you have a strong family history? Because that may be important too. And if you do, then our suspicion meter goes up. Anyhow, based on that, we then want to do imaging. Imaging tells us a lot. So the first line of imaging today tends to be something we call MRI, magnetic resonance imaging. And it's a way of looking at the prostate and making a determination by the radiologist whether or not you may or may not have cancer. So just so you know, 10 years ago, the radiologist couldn't tell us a whole lot. Today, they've gotten really good. And the reason why they've gotten really good is because they're now using these very powerful magnets, which enables them to focus better on the prostate and the tissue within the prostate. And they're using a coplanar range of beams, and they use something we call algorithms, which predict whether there's a cancer or not. So while 10 years ago they couldn't tell us much, today they tell us, oh, there is a cancer. And then they go on to say, not only is there a cancer, but we predict it's going to be this aggressive. So when they look at it, they have a score that's called PIRADS. So that scoring of theirs goes from a 1 to 5, PIRADS 1 to PIRADS 5, and everything in between. They've identified that if a PIRADS 5 or let me say, if a cancer is very aggressive, or they think it's going to be very aggressive, they'll categorize it as a 5. If they think it's not aggressive at all, they'll give it a 1 or 2, and then there'll be 3s and 4s in between. But that is their prediction, and they've gotten really good. So these days, when a radiologist tells us from a good place with a good MRI, with a high Tesla magnet, using something we call multi-parametric analysis, we pay attention, and that could be a reason why we would do a biopsy right there, because it can show us a PIRADS lesion that we feel is warranted to be biopsied. Now, there are other factors that could be used, and sometimes, for example, a patient comes in, he does have a strong family history. He's had an MRI, but it's equivocal. It's not showing us any cancer. You know, the radiologist is not saying, "Oh, you have a cancer." He's saying you might have a cancer. We do use one other way, and it's called a 4K score, which is another predictive score using your urine. Okay, so in your urine itself, it can tell us whether you have a cancer or not, or the probability of your having a cancer. It's not 100%, it's not foolproof, but sometimes we need it just because there's reason to be suspicious, but we don't have, here it is on an MRI. So those are the main things that happen in terms of when you should get a biopsy. Now, moving to the biopsy itself, there are ways of doing the biopsy, and the most common way is through the rectum. So what happens is a probe is placed in the rectum, and through that probe comes out a tiny little needle, okay? And the needle then enters the prostate tissue, which is right in front of the rectum. The prostate is. That's called transrectal ultrasound biopsies, okay? And I'd have to say that's the most common way of doing biopsies in the United States and world. Apparently, this is still what's being taught, to urologists. So most urologists, 99.9%, are going to recommend, if you need a biopsy, a transrectal ultrasound guided biopsy approach. I have issues with that, and the main event can be the fact that you are going through the rectum and you just can't make that rectum clean. You can't scrub it down like we do in surgical scrub. You can't do it. The best you can do is a bowel prep, but it's always going to leave bacteria in the rectum, and you can't see bacteria, so that when you do go through the rectum to get to the prostate, you are introducing bacteria into the prostate. The prostate can then share that bacteria with your urinary system, and you can get a urinary tract infection, which can then share it with your whole body, and you can get sepsis and end up in the ICU in a hospital. So that's a really big deal associated with the approach through the rectum. The other issue with the approach of going through the rectum is that you have to go through the rectal wall. You then have to go through a fat plane to get to the prostate, and you may just not be able to get to the whole prostate gland. So these are issues that many will run into, but patients won't know about, and that's an issue. The third is that the rectum does have a lot of pain sensors, and most rectal biopsies will be painful, and that's just the nature of it. Now, hopefully you'd be anesthetized, when it's being done, but because if not, I know patients will be screaming. I did them a long time ago. I wouldn't dare do them now, but it is a painful procedure, and even after the anesthesia wears off, you're usually really hurting, and it smarts for a long time. So that's another issue. And then finally, we're always thinking about, well, if we're doing a biopsy, we're thinking you might have cancer, and if there's cancer and we're going through the rectum, well, the rectum has an awful lot of big blood vessels, and again, you can't see those when you're doing your rectal biopsy to the prostate. And so you typically engage some blood vessels, and there's data, and you could just, use Dr. Google to find that patients having transrectal ultrasound guided biopsies do have potentially dissemination of cancer if there was cancer in the gland. And that's a problem. Okay, that's a small percentage, and I wouldn't, tell a patient don't get it for that reason, because it is a very small percentage, but it's real. So those are the major reasons why we do biopsies, and those are the ways that commonly biopsies are done, but not here. And there are other places in the country and different centers around the United States that do it differently. We do biopsies not through the rectum, but through the perineum. Now that's a small area between the scrotal sac and the anus, and it's a tiny area, but it's really close to the prostate. And the advantage is that we can scrub it down. We can use betadine to make sure there's no bacteria there before we enter our tiny little needles, which then go directly into the prostate, which again is really close. It's right there. And there's no area of the prostate that we can't assess. So in contrast to the rectum, where you have to go through the rectum and some fat layer and to get to the areas you're concerned about, we don't have that issue with the transperineal approach, is what it's called. The other, so that infections are really, really rare. Okay, we will still use some antibiotics, but they're really, really rare. The other issue is there's not a lot of pain sensors in the perineum. So when we do go into the perineum, there's less pain. We still do it with anesthesia, and right after my biopsy through the transperineum, I do something called a nerve block, where I block the paraprostatic plexus and some of the pudendal nerve, and that gives a patient a lot of relief from that biopsy procedure. And we're not engaging any big vessels, but there are still some vessels in the prostate that are small, so you could still get some urine, blood in the urine, but it tends to be more of a closed loop, so there's less concern also about dispersing cancer from that procedure. So that's called transperineal prostatic biopsies. Now, one thing's for sure, and that is most places also, when they do the biopsies, they're fusing the MRI information that you had. So, you know, most patients that I see, they've already had an MRI, and most patients urologists see already have an MRI. And so when they go to the procedure room or the OR, they basically fuse the technology of the MRI and what they're doing right there, so they can have a direction knowing where the MRI found an abnormality. The problem with that, though, is that you cannot bring the MRI to the procedure room, and things change. So whenever I'm doing a procedure, I know patients are going to move. You can't help it, you know, and the area itself moves, but the prostate does move during biopsy. So what I do is, there's another test that I've been involved with for some time. It is an ultrasound, but it's an ultrasound that's pretty special. It's a very high-end ultrasound. It's called a three-dimensional color flow power Doppler ultrasound. It allows me to visualize the prostate, and perhaps better than the MRI can show me. Both MRIs and ultrasounds typically are basing what they see on density gradients. And so we, with our ultrasound, can also see density gradients, but we can also see vascular patterns. Cancers have select vascular patterns, which are clearly cancer. You know, if we see something, if we do see a dark spot, and that dark spot happens to have a glow of vascularity associated with it, you know, it's pretty much going to be a cancer. And I published on that. In the back wall, there's a study that I published showing how probable it is, if we see a dark spot and color Doppler ultrasound abnormalities, that it's going to be a malignancy. So that's something that I do watch actively, and we don't have to worry about your moving, because we can move with you with the ultrasound. It is brought to the procedure room. And so that's how we do it. When a biopsy is done, we send these little snippets to the pathologist, who then tells us what you got. And some of the things that we want to learn about is, what is the aggressiveness of the cancer that I just biopsied. And so there's a way that the pathologist looks at it, and when he's looking under the microscope, he identifies the most common cancer in that snippet. And he says, okay, on a scale of 1 to 5, where do I put this cancer? And let's just say he says, on a scale of 1 to 5, 5 being the most aggressive, it's a 4. So he said, okay, so that number is a 4. And then he looks again, and he said, what is the second most common cancer that I see in this snippet? And he said, okay, well, that looks to be a 3 from a scale of 1 to 5. So what he does do then is combine the two, so you get the 4 plus the 3, and that equals a 7. So obviously, you just think about it. It could be a 3 plus 4 can also equal 7. A 4 plus 4 would equal an 8, and 4 plus 5 equals 9, and so on and so forth. But that's how he tells us how aggressive a cancer is. And that number that he assigns is called a Gleason score, formerly known as a Gleason pattern score. And you'll read or hear about that. I think we all heard about President Biden having a Gleason 9. So that means he's got an aggressive cancer, okay, and treatable but aggressive. So that's the Gleason score. The second thing that the pathologist then tells the oncologist, urologist, is how much tumor was present in each snippet. And that's important too, because the data suggests that if there's 30% or more, then that can affect outcomes of treatment. Primarily radical prostatectomy, though. That data is based on prostatectomy, and it's specifically saying if there's more than 30%, then there is a higher failure rate associated with that approach. The third thing they tell us is, are there any nerves involved? Because the prostate has a lot of nerves running through it. After all, the prostate is it is a sexual organ, pure and simple. It's the G-spot in men. It has a lot to do with the creation of the ejaculate. It has a lot to do with the orgasm, and it has a nerve network going through it. The importance, though, is that if the pathologist tells us that there's cancer on a nerve, then we think that there's a higher probability of the cancer getting out. Okay, it kind of gets a free ride. It's like it's a canal. It's an area that the cancer just kind of jettisons along and escapes the whole region. So perineural invasion is what that's called. And then there's also some other features about a cancer that the pathologist will tell us if they're there, and they're about the architecture. So we now know that if a person has specific architecture, one is called a cribiform pattern. If there's a cribiform pattern, that suggests that the cancer, regardless of the Gleason score, can behave more aggressively. There's also one called intraductal, and that means it's another architectural change that's associated with very aggressive cancer. So those are the main things that the pathologist tells us with respect to biopsies, and that's how we go about deciding whether a person should or should not be treated, which is the whole nother area within the framework of prostate cancer. Anyhow, long answer for your biopsy. Yes.
With the biopsy question, do you recommend or do you usually do a regimen of antibiotics prior to or throughout the treatment?
So she's asking about antibiotics. We typically cover you with antibiotics during biopsy. We usually cover you with antibiotics during the procedure. We give you an IV antibiotic. We have our favorite one that we give you during the procedure, and typically after we give you something like Cipro for a short course at a time, but not for a long period of time. And we just don't see a whole lot of infections. I guess we're just very cautious.
And then off the biopsy topic, if the cancer is in the lymph node, do you just remove the lymph node or nodes?
So she's asking about a phenomenon that cancers are accustomed to doing, and that is going to these little organs in our bodies that we call lymph nodes. Lymph nodes are in our bodies to remove things that are not supposed to be there, and we have a lot of them in our body. In fact, there are more lymph nodes than we have vessels in our body, okay? And they start down in our toes, and they go all the way up to behind our ear. The pattern of flow tends to be upwards, and lymph node or lymphatic drainage, what we call it, tends to begin down there, and it's a constant upward trend, and that's how the flow of lymphatics go, and they end up going under the neck. The only place they don't go up is behind the ear, and the lower, in this part of the neck here, they go down to the lower part of the neck, and that's where they empty. So lymph nodes, we may all know lymph nodes as something that affected us when we had a swollen lymph node under the neck, accompanying a sore throat, because lymph nodes typically are associated with inflammation and infection. They remove it. They remove things that are not supposed to be there. So prostate cancer, however, let me say cancers in general, also foreign, and it removes those too. So it immediately identifies something foreign beyond inflammation and infection, and it grabs it up, just like the infection in your tonsil or throat caused a swollen lymph node in the neck. So with the prostate, so we have, so this is the prostate. It's shaped something like this. there are lymph nodes that live very close to the prostate, and there is a drainage pattern from the prostate out to these lymph nodes. And they're really close, and they're very plentiful in the pelvis. You know, there's two organs in our bodies that are similar. One is in women, it's the breast, which is fed by the female hormone estrogen. The other is the prostate, fed by the male hormone testosterone. And they both have this propensity to go to lymph nodes quickly. And if you know anyone who has breast cancer, they're often talking about the lymph nodes under the armpit. Okay, and that's because lymph is rich in that area too. So they're very similar from that perspective, the prostate and the breast. But anyhow, with prostate cancer, they go to these lymph nodes pretty quickly. They tend not to go to these lower ones. It usually starts about right here and up. They're called the iliac lymph nodes, which are commonly affected with prostate cancer. We were involved here before. Now, many of you may know what a PSMA PET scan is. It's another way of looking to find if cancer has spread of your prostate. But we were using a nanoparticle test between 2008 and early 2019 right here. And we were working with some very large places like University of California, San Francisco, and the University of Nijmegen in the Netherlands. And we had some of the largest body of data on nanoparticle tests. And we would inject this nanoparticle, which was called USPIO, ultra small superparamagnetic ferrous oxide nanoparticle. And what it would do is it would show us where cancer was of the prostate. And boy, it showed us just how common it was for prostate cancer to the lymph nodes. It was like almost everyone has lymph node dispersion microscopically. You don't see a whole lot of it with other imaging because you got to get a bulk of tumor in the lymph nodes in order to see it with the typical staging like MRIs and CAT scans and even PET scans. But the nanoparticle showed us it was very common for lymph nodes to be involved, and for that reason I do treat lymph nodes associated with the prostate whenever possible. Interestingly, a long time ago, when surgical removal of the prostate was done in a bigger way, when they actually used to do an incision from your belly button down to your groin, they would open you up and remove a whole bunch of lymph nodes on each side, 10, 15, sometimes up to 20. And that's what they would do to find out if the cancer had spread to the lymph nodes that they were removing. And they did find that a lot. The problem that they found, however, was that the patients who had that done would often have something of a problem with drainage of lymph nodes. And we called it lymphedema, where the legs would swell and the scrotal sac would swell. Again, everything is going up. And when it got to the lymph nodes in the pelvic area, it was blocked because they were gone. Okay, they had removed them. And so that practice is abandoned. Today, with radical prostatectomy, which is done by the Da Vinci robotic procedure, they hardly remove any lymph nodes at all. And in fact, it's rare for me to see more than 4 lymph nodes removed by radical prostatectomy. And the ones that are typically removed are the ones down here, which, as I said, are not even the ones that are classically affected with prostate cancer. So lymph node treatment is an important thing when it comes to radiation. And immediately after we looked at the surgical data of patients having swelling of their legs and scrotal sacs, then the question was, well, what's going to happen, with radiation? Are these patients also going to end up with swollen, testicles and legs? And they didn't, and they don't. And so now we know from a lot of data of years, decades, that you can treat the lymph nodes, and it's very safe. And the lymph nodes continue to function in terms of what they're accustomed to doing, draining your body and not causing a backflow. So that's the story with lymph nodes.
I got a question. You're talking about the treating of the lymph nodes. You're not removing them or radiating them?
Right, it's radiating them.
And that doesn't kill them?
It does.
Okay.
It kills the cancer in the lymph nodes. It doesn't kill the lymph nodes in terms of what they do. Again, lymph nodes are there to remove things that are not supposed to be there. That's what they do. And so with surgery, we found when you remove the lymph nodes, you're surgically removing them. You're blocking the chain. And so things block up. Okay. In contrast with radiation, it kills the cancer cells, but the lymph nodes continue, or the lymphatic drainage continues to flow unimpeded. So it's not a problem.
Just another question. The seeding that you talked about, read about.
Yeah.
During that process, that treats those lymph nodes, or is that a separate treatment?
No, so the lymph nodes, so he's asking if the brachytherapy, which is what it's called, where we put these tiny little materials into tumors. So with that type of treatment, what we try to do is, these are tumors in the prostate. We try to put seeds in and around these tumors. And it's a really precise type of radiation. In fact, to this day, there is no more precise type of radiation than brachytherapy. There just isn't. And we like to use a low dose rate material, which means you put it in and you forget about it. You don't have to worry about it because it just runs out of energy. You put them in, they have energy and they dispense themselves, but they're really precise. So where you put them is where it works. Okay, and in fact, that's the reason why you better be knowing what you're doing, because if you don't put them in right, you're going to miss. Okay, but for the same reason, if you step outside, the dose gets to be very low. Okay, almost nil. And by the time you get to the lymph nodes, it's just not significant. So for that reason, brachytherapy is a great treatment for patients who have 100% confined disease in the gland. But if there's any element outside at all, then it's going to miss. Same with surgery. Surgery better be 100% in the gland. Otherwise, if there's any element outside of the prostate at all, you're going to miss. This is actually one of the big deals, or my issues I have with radical prostatectomy. Currently, it's used as a da Vinci robotic procedure. And one of the important elements is that tumors of the prostate almost always begin in an area that we call the peripheral zone, the periphery. Okay, they don't begin in the central or transitional zone. It's right on the edge. They're called the peripheral zone. And that's important because the prostate doesn't have a capsule. Okay, and some will argue, well, it may have a pseudo capsule. It really doesn't have a capsule. And the reason why that's important is that whenever we hear about cancer anywhere in our bodies or someone else's body in an organ, and you say, oh, it escaped, what it typically means is that the cancer began in that site and then bored its way through the capsule to get out. Okay, but what happens with the prostate? Well, it doesn't have a capsule. And so while cancers, what defines a cancer is its ability to spread locally, infiltrate the tissues around it, and then to disperse into the bloodstream. But from the standpoint of the tissues around it, well, it's going to do this. It's going to send its little feelers into the tissues around it. And I often talk about spiders, with the body being inside the prostate that you maybe can see with an MRI or an ultrasound or a CAT scan. But what you can't see are these, but they're there a lot. Okay, and the higher the volume of disease, the higher the probability that they exist. And the reason why that's important is because when you remove the prostate surgically, you can't go like this, take a big swath around it. You just can't do it. Okay, I've been involved with these procedures. You can't do it, and because of that, what you basically do is peel it off like this, and you come around. And you do have to remove. So the prostate, which has a right and left side, right here, there's a really big valve. We call that the internal sphincter of the bladder, which is bigger. It's off this page. But anyhow, when you remove the prostate surgically and you do peel it off like this, and let me tell you, if there's an area that you're really concerned about, you say, well, I'm going to go a little wider. I'm going to go like this. But you don't know. You can't go like that. You just can't do it, because if you did, you'd be sending a patient into the ICU for a long time to heal, and no one does that. So it's basically peels it off. But you do have to remove that big sphincter of the bladder, and that's a huge deal because we've been using that sphincter our entire life to control our urine. And it does 95% of the caseload of urination flow patterns. It opens when you know you got to go. It closes when you want to stop it. When you feel you got to go, it's because there's pressure on it by either tumor or the prostate. And it's all about that sphincter, but that is removed at the time of surgical radical prostatectomy, and it's a big deal because it becomes a lifelong issue. And since prostate cancer afflicts men typically as we get older. Okay, our muscles are getting weaker year after year after year. And so now this is gone. And so the urine that comes down the prostate through the urethra now goes out. And there is another group of sphincters here. They're called the external sphincters. This is the internal. This is the external. These guys are really small, and they haven't been challenged in much of your life. You just haven't had to use those very much. And after the removal of the prostate surgically, however, then you have to rely 100% on these, and that's a problem because they're typically just not up to the task. And many men do spend a good period of time, a year or two, trying to build these up with pelvic floor muscle exercises. One is called Kegels, biofeedback, all these other things to try to strengthen that muscle because, you know, the flow of urine is water and water finds its way, and it's going to find its way through that. And but it's almost a losing battle because what happens as time goes on, even for the guys who find that they manage to get better urination control, but as they get older, it just becomes weaker and weaker, and then it's just a matter of urinary flow. And I know many men who've had their prostates removed surgically really regret that because, you know, at first our whole concern is, you know, let's get rid of it, let's cure the cancer. Afterwards, once the cancer is cured, then the big concern is, oh my God, I got all these nasty symptoms and I got to live with them for the rest of my life. These are issues, but with respect to prostate surgery, if you just think about this picture, you removed the prostate, but you didn't remove these guys. And you certainly didn't remove these lymph nodes. And that's a big deal. And that's the reason why also, you know, after the robotic radical prostatectomy, many men, depending on every case is different, they find their PSAs are rising again. And that's a problem because now PSA is rising. And why is it? Is it rising because these were there? Is it because the lymph nodes were involved? Is it because the procedure, which I would argue also is too bloody of an operation for cancer removal? And again, you know, you could use Dr. Google to find out just how much blood is spilled at the time of a robotic radical prostatectomy. It's a lot. And just as I told you, prostate biopsies through the rectum can spread cancer. Well, boy, it can really spread when it's a bloody operation and cancer is living right here and you're cutting around it and the cancers can disperse. There's a lot of recent data and even old data showing that patients who've had their prostates removed surgically do have a higher failure rate up here, you know, distant sites, liver, lungs, bones, things like that, as a result of the blood spillage at the time of that procedure. But what happens, you see, is, again, you really don't know where the cancer is after surgery and your PSA is rising. And so, whereas a patient being treated, for example, here with the prostate intact, and this is much smaller, by the way, but anyhow, you know, we can be very careful about where we're treating. And we can go to these little lymph node sites very carefully and precisely. After a patient's had their prostate removed surgically, we have to be careful not to be overly precise because we may miss it and we don't know exactly where it is. So many talk in radiation world about a radiation bath, meaning now you're just going to treat the whole area with radiation and you're not going to be precise about it. And these are issues because they just bring up complications. Because with radiation, you don't want to be overexposing normal tissues, but you have really no choice after a patient's prostate's been removed. So these are issues, okay, associated with. So seed implantation, very precise, similar to surgery, but it can miss these tentacles.
How do you treat the tentacles then?
So the tentacles, what typically happens is, what we do is with radiation, we treat the prostate, okay, and then we feather. These tentacles aren't going typically into the rectum. They're not going up to the bladder. They're not going in the front. They're typically going right, left. And there's an actual pattern of failure going from the prostate out. So we treat that area out. That's going right to the lymphatics to the side of it. So it's an area that's right off the prostate. We call it the posterior lateral region of the gland. And that's the area that tracks along when we treat that area. Okay, and of course, the other thing that happens is with just a small dose is that if you just think about your prostate as a palm and your fingers, those tentacles, after you give a certain amount of treatment with the radiation, these tentacles rescind back into your palm, and now we do the brachytherapy to the fist, and that makes a lot of sense. So, okay. Anything else? Yes, sir.
What circumstances, if any, would you not recommend any treatment?
So, with patients having prostate cancer initially diagnosed, what we look at is that Gleason score that I've mentioned. And what we do in those cases is say, okay, is it a Gleason 6 or is it a Gleason 10 or somewhere in between? So what I look at is I say if it's a 7 or greater, I don't recommend doing anything. I do recommend always treatment. If it's a 6 and there's only a couple 6s in one area, of the gland, like here, then what we say is, well, we can follow that, okay? But we need to be careful when we do follow a patient having prostate cancer because it is cancer, okay? And cancers don't go away, okay? They can grow more slowly, but they don't go away. And what they like to do is change over time, and so they mutate. And when they do mutate, they always become something more aggressive, okay? And so the other thing that we look at is even in a person who has just a couple areas of Gleason 6, what's the volume of Gleason 6 there? Because if there's a lot of Gleason 6 volume, well, it's going to morph into becoming something more malignant, which is more lethal. It will become a Gleason 7 or a Gleason 8. So for those reasons, we do treat, but there are patients, and I have lots of patients who we do something called active surveillance. And what we recommend in those men is to be followed closely, to get periodic. In our case, we use the 3D colored Doppler ultrasound as a barometer for what's going on. And we could, because now we have the advantage of knowing exactly where the cancer, was. And we can track it with a 3D Doppler ultrasound. If necessary, we do another MRI at some future date. But at some point, if we think that the cancer has gotten outside a little bit in a bigger way, then we do make strong recommendations to be treated at that time. And as I say, with higher Gleason scores, I'm just not comfortable doing active surveillance because, again, cancers are cancers, and even Gleason 6s can spread. I have a lot of men who I've treated through the years who did active surveillance for a certain period of time. And then when we finally did a workup, because they got nervous about being, not being treated, or maybe their PSA started going up faster, and then we did we did a wide body PET scan or the nanoparticles to find that it had spread, to bone and lung and liver and things like that. So cancer is still cancer. What makes a cancer is ability to grow faster than normal tissue, and its ability to invade tissue around it, and its ability to spread to different sites. It likes to get involved with the vessels of your body, and that's what I was talking about with the colored Doppler ultrasound and why we see it so readily. And by doing that, it can then gain access to the rest of your body. So these are concerns, but some patients, and then there are other areas where a guy may have a borderline, which maybe we don't have to treat, maybe we do, but he's got a lot of comorbid medical problems. We can predict that he's not going to be around that long. Okay, and so we have to think in terms of what's the right thing to do for each and every patient. So it's easier when someone does have more aggressive cancer or there's very high volume disease in terms of what to do, because then at least I recommend treatment. I think most do, although there are some out there in these days that are putting patients at risk. The patients, I don't think they know it, how much risk they're really being placed at. So, but anyhow, those are things that we do here that are, interesting. Yes, sir.
Can you go over the timeline of, let's say, entry into the lymph system, what the treatment, how many days of radiation, the brachytherapy, and the hormone process?
Yeah, so let me, based on hormones, let me start. He's asking the timeline of things, okay? And I'll start off by talking about hormones, because hormones are commonly used for prostate cancer, especially if it's a more aggressive type of cancer. Okay, I don't use hormones in every patient, and when I do use them, I do use them judiciously. I don't like to overexpose a patient to hormones because they can cause an awful lot of side effects with time. Okay, so if you look at that body of data, when you do get hormones, most studies suggest that it's that during the radiation regimen that you benefit most from hormones. And there's thinkings behind that. Some of the thoughts include that the hormones themselves do have cancer-killing properties, so that the radiation has less work to do because many of the cancer cells have died from the hormones. The second thing that happens is cancers are placed in a more vulnerable phase of their growth phase. As they go through their mitotic cycle, they're put into a more vulnerable area of their mitotic cycle when radiation hits it better. And so that's the second theory. And then the third theory is that hormones also boost your immune system, which again is interesting because as I was talking, chemotherapy, that drops your immune system. Surgery drops your immune system. Hormones increases your immune system, as does radiation. So that's also a function of radiation. And the current thinking, and there's a lot of thinking about this, is that when you give simultaneous radiation and hormones, that you're causing a peak, a spike in the immune system of your body. And that can actually send out information to the rest of your body where there might be cancer cells and knock them out. But the whole concept of using hormones and radiation, if you look at the data really carefully, as I have, I find there to be most of an advantage when you're doing them simultaneously. Now, every case is different, and there's some patients where you also say, well, there is a higher risk of this person harboring cancer elsewhere in the body, and I'm not treating elsewhere in the body. We can't see microscopic disease, which might be throughout the body, and for that reason, we have to use our hormones for a longer period of time. Okay, just to make sure that we kill where we know the cancer is, where the bulk of the cancer is, but that we also knock down cancer that we don't know where it is in the body. But again, every case is different in terms of who we use for what. I think generally speaking, when it comes to hormones, I'll always use less hormones than most others, just because I do appreciate the fact that they have a lot of side effects, and I've been involved with a lot of studies and have evaluated just about every study out there to find there's not a whole lot of advantage. On the back wall, I have some of the data that I published, which is some of the longest data ever published for prostate cancer and in the journal Cancer, and it showed that we didn't need to use hormones beyond a certain period of time, and it really fortified my belief of what I've told you, that it's that during the radiation regimen that appears to be the most important for those reasons.
But if you could, I guess more specifically, the question is, I read somewhere that there's 40 daily radiation.
Yeah, sure. So the concept with radiation is, and again, there's a lot of data going back into really the 50s with radiation and safety measures, and so it's all about that. So the two things that we try to do is deliver a high dose and do it safely. Okay, and that's what we do. So with radiation, we know that doing it more swiftly, you're giving a higher dose at a shorter period of time. You're subjecting normal tissues to that, and normal tissues have a problem with that. Okay, the cancers, they fold. Okay, they do, but it's the normal tissues that have a problem with repair. And so we don't like to use quick regimens. And I know, again, there are places out there doing it ever so swiftly, with radiation. But I think if you look at that data, like I do and other investigators do, you'll find that short-term regimens of, 3 weeks, even 4 or 5 weeks, are associated with higher side effect profiles. There was a recent study which looked at patients being treated. It was about 4 to 4.5 week regimen. And at 14 months, they had a 10% rate of fecal incontinence, where the stool is. And that's because it had weakened the muscles so much, it injured those muscles. And by then you would have expected, well, it's not a temporary thing. It's already 14 months. But, you know, if you just think about that, as that data accrues, it's only going to get worse. So for all those reasons and the reason that I published my own data, so we typically recommend longer courses of treatment. And most of you will know that up front, we usually use about 6 to 7 weeks of the DART radiation. And then there is a pause, and the pause is generally between 10 days and 2 months is what we typically tell you. And for those of you who say, well, which one is it? Is it 2 weeks? Is it 2 months? And the reason why we have that flexibility built in the program is we've looked at it. We've been involved with clinical studies, and we've done multivariate analyses looking for variances to see if a person does better if he was treated 3 weeks after the completion of DART with a seed implant. If he comes back 6 weeks after the DART to get a seed implant, there's no difference. There's no difference at all. So based on that, we've made our recommendations, typically 10 days to 2 months. And I got to tell you, we treated patients, people get into car accidents and have heart attacks, and we've treated patients 3-4 months out, even longer. And they seem to also come within the folds of what we expect in terms of, cure rates and control. So, any other questions?
Yeah, one more. So the seed implant comes after the radiation, and that's typical treatment.
So the DART is done first, okay, and for many reasons, one of which, as I told you, if you just think of your palm as your prostate and those fingers, what will happen is over the course of those 6-7 weeks, those fingers will rescind back into your palm. Now is a perfect time to do the brachytherapy. And I do believe that combination regimen is very advantageous. Cancers don't like change. And when you're doing something to them that's the same every day, there are some cells that try to defy what you're doing to them. And that's where brachytherapy can come in really handy, because it's completely different. The cancers don't recognize it. They've been getting this photon therapy or proton therapy every day, and now you're changing the menu and you're using brachytherapy. Having said that, I've also treated a sizable number of men with just the DART. And for reasons that, they don't want to have anything, even if I try to tell them it's a minimally invasive procedure, we're not going to have to talk about incontinence and all these kinds of things. They may still just want the DART alone. And of course, it's a good treatment. I don't have the data for that. That's the problem. I have the data with combined modality regimens. Okay. And again, I published extensively on the combined modality regimen where we use a version of radiation followed by seeding. I know I've done more than any person in the world of that combined regimen. And that's what I can talk mostly about, because of those really high control rates, which I would argue far superior to surgery and far superior to other forms of therapy. But what if we were to push the envelope with the DART and be more selective and intensive and focused with the DART, maybe at the end, take the place of a brachytherapy boost? I don't have that data. Okay, so. Yes, sir.
Because you know me, I just let everybody know I'm in the therapy now, and I missed the last one of these prostate tests, days.
Okay.
I'm learning a lot.
Right.
Anyways, you talked about using the hormone therapy and stuff, but you're decreasing my testosterone. And how is that? How is that different from adding testosterone or adding hormones to what you're doing? Because I had high testosterone.
Right.
And suppose that cancer is feeding on that.
Okay.
From in some venues and stuff. And so, it's that kind of mixed information. So if you're using therapy, how are you using it on me in decreasing my testosterone to the extent it's being decreased?
Right. So again, prostate cancer is fed by the male hormone testosterone. Okay. There are other things that feed it too, like prolactin, and which is another hormone produced by the central axis of the brain. There's and some other things like dihydrotestosterone, but we think in terms of prostate cancer fed by testosterone, so we take away the testosterone.
In that thought, so does the breast cancer feed on estrogen?
It does.
Okay. So
It
that
does.
that was my biggest. Okay.
Right. Yeah. They're flipped. The screen is flipped.
Okay. So
Yeah.
then you're doing that. Okay.
Yeah.
So
Okay.
there's the difference between all these cancers.
Oh, they're completely different. They're completely different. But yeah, you know, the hormones, as I said, so the primary hormonal therapy is dropping your testosterone. The second areas that we're interested now, as I told you, which this company is sponsoring, it's an androgen receptor inhibitor, which doesn't drop your testosterone. It just doesn't allow the testosterone to tap into the cancer. So it blocks it right at that level of the cancer receptor. In the process of doing that, it doesn't drop your testosterone.
That may be the one I just started.
Yeah, yes. We typically use them both. Okay, so we typically use the testosterone starving one, and then if we can, and the reason why I say we can is these androgen receptor inhibitors are very expensive. Okay, and not every patient can get them, and not every insurance company will allow them. That's the unfortunate part of it, because otherwise we would be using even more and more. But anyhow, fortunately, you know, these big drug companies like Janssen and others have big compassionate care programs, and you can get them, and they don't cost an arm and a leg, and we just do a lot of paperwork to get them to you. But the data with radiation and hormones, and the advantage of radiation and hormones, where one makes the other work better, is still the primary hormonal therapy, the one that drops the testosterone. So we still do like to use that up front. Okay.
I'll say one thing, because
Yeah.
I'm going through the doctor right now, and next week's my last week. It's a piece of cake. The biggest pain is every day coming here and interfering with your life. But it's, it's because they're doing a lower dose, and they're not doing, I've heard of so much stuff over the years. My brother got, I don't want to do a lot of it, but you hear about all this stuff where people had babies, and people had been basically butchered by these doctors over the years. Doesn't happen here. That's why I came all the way from Maine for this, because I studied it. I put my cancer mine off for many years, because I 30 years ago when I heard about they go up the butt and get a biopsy, it didn't make sense to me. I talked to him here, sent him all the information, got a call. Doctors talked to me for 45 minutes and answered all my questions, and told me a lot more. And everything made sense to me. It was smart. It wasn't, and they tried to ask questions with us mainstream, and they didn't have time to answer the damn things. So just want to pass that.
Thanks.
Aside from having to be here every day doing treatment.
Yes.
I let
Are there any lifestyle changes to anticipate from the treatment itself?
Yeah, from a lifestyle perspective, we don't ask you to change anything, and most patients don't have a change. We ask you to just do the same things you're accustomed to doing, whether it's exercising, whether it's swimming, whether it's, we would like you to eat healthy, and we would guide you along those lines too.
Okay.
And just to clarify, the DART treatment is 7 days a week for.
It's 5 days a week, 5 days a week. Yes.
So,
Yes, sir.
thank you. I think I'm going to my 7th year cancer-free, so
Okay.
thank you. So what are some of the reasons that people you find didn't want to do the seeds after dark? Because it seems to be a more complete process.
There are people that just don't like needles, and after they got through their biopsy, they're like, I'm never doing that again. Not with me, but with other doctors. It's just kind of the way it could be, and they just don't want to hear about it. So that's all I can tell you.
There's a lot of misinformation out there.
Yeah.
I have one more question.
Yes, sir.
If I've already had everything done, I've already had the biopsy, the MRI, the PET scans, do you guys repeat that, or do you accept what I've already got?
No, Yeah, we accept what you already have. We want to look at all your tests, you know what I mean? We look at it with a fine tooth comb ourselves, make sure nothing was missed. But we do, we use everything you have. We do our own studies though. You know, we do use a 3D color Doppler ultrasound to better define where things are, and we do light speed helical scans and things like that.
Just a quick question, when you mapping it all out, how many scans do you actually use to put together that map of my prostate to pinpoint where you're gonna put this?
Yeah,
How
many thousands.
Yeah, there's quite a few scans. I can't believe the technology information that goes into.
Yeah.
But, and then if you talk to Joan and see what she's doing, it's incredible, awesome. It's a whole
Yeah.
detail, your whole thing.
That's right.
Right.
We have a really good team here. We've assembled a top-notch team, a world-class team. All right, well, I'm gonna have to break, and I gotta see patients. But thanks for coming. We do this once a month.